Fighting Blindness Canada's Viewpoint Education Series shares the latest in vision research, provides opportunities for you to ask your questions, and connect with other people who are living with a blinding eye disease. The session you're about to watch is a recording. To learn more about the research we fund and upcoming programs and events, please visit our website at fightingblindness.ca. Viewpoint is proudly presented by our Platinum partner Bayer and supported by our Gold partner Roche and Silver partners AbbVie, Astellas, Beacon Therapeutics, Johnson & Johnson, and Specsavers. Thank you for watching. We hope you enjoy this session and share your thoughts with us in the comment section below.
Welcome, everyone. I'm really happy to be here and have such a wonderful panel of experts to talk to. So I'll invite our speakers, Dr. Maldonado, Dr. Qian, and Dr. Huckfeldt to turn their cameras on while I give brief introductions to who they are. So Dr. Rachel Huckfeldt is an assistant professor of ophthalmology at Harvard Medical School and a clinician-scientist at Massachusetts Eye and Ear. She specializes in inherited retinal diseases, or IRDs, as we keep saying, and leads many natural history and interventional clinical trials. We also have Dr. Ramiro Maldonado, who is a clinician scientist and ophthalmologist at Duke University Eye Center, and he specializes in medical retina and ophthalmic genetics. His research focuses on developing diagnostic tools for pediatric retinal diseases. And finally, we have Dr. Cynthia Qian, who is an associate professor of ophthalmology at the University of Montreal. Dr. Qian specializes in inherited retinal diseases with dual fellowships from Harvard Medical School and the University of Michigan. So thank you all very much for being here. And we have invited Dr. Huckfeldt to discuss advances in X-linked retinitis pigmentosa, or XLRP, Dr. Maldonado to discuss X-linked retinoschisis, or XLRS, and Dr. Qian to discuss choroideremia. But I know that their expertise and their practices are far more wide-ranging than just that one specific disease. So I've asked them that if they have anything to add to the conversation, to just jump in as they feel fit. So we are discussing three conditions, and sort of the common thread between them is that, of course, they're all inherited retinal diseases, but they're also all X-linked, and that means they primarily impact males, although I know that's slightly different for different conditions. But they also are quite different from each other as well. So I thought to start out with, it would be really good to start the conversation with a brief description of each of these diseases. So I'm going to ask each doctor to briefly describe each of the diseases and how it impacts patients. And I'll start with Dr. Huckfeldt with a brief description of X-linked retinitis pigmentosa.
Thank you, Larissa and everybody. It's really wonderful to be here. And I was going to ask Larissa, I'm happy to talk about whatever you want.
It's X-linked RS. Yes.
Yeah, wonderful. Okay.
So please start. Yes.
Yeah, it's great to be here with you all today. I will start off by talking a little bit about XLRS, as I'll abbreviate X-linked retinoschisis. This is a condition that we know typically shows up in school-age boys. A recent study said the average age of diagnosis was around age 5 or 6. And it shows up because they have a hard time with straight ahead central vision. So you think about a child starting school, and that's often an environment where challenges with vision can be picked up. And a frequent occurrence is that a child may have a hard time on a school vision screen. Will go to some kind of eye provider, whether an optometrist or ophthalmologist, have a hard time being corrected to the smallest lines on the eye chart with glasses. That will lead to further assessment, and that in some cases will lead to a diagnosis of XLRS. This word schisis and its name refers to the splitting of the layers of the retina that is characteristic of XLRS. And we can see that when we look into somebody's eye on clinical exam. We also have ways of imaging that highlight that. And then an additional feature that can happen in about 50% of men and boys with XLRS is having peripheral splitting or schisis of the retina. There's a lot of variability in terms of whether that's present and how severely that's present. But as we think about the best way to take care of an individual patient, we are thinking about the macular schisis affecting central vision, and also what concerns or precautions we need to take with peripheral schisis.
Can I ask, is there any way to know if somebody will have either the macular versus the peripheral schisis? Is it based on where the mutation is in the gene, or is there other factors that we know about?
Yeah, that's a great question. Thank you for that. So the macular schisis is a pretty universal part of the clinical condition, at least in the early decades of life. Later on, as people age, it may fade away and no longer be present. It's a little bit less predictable if, why, and how people have peripheral retinoschisis. And to the best of our knowledge at this point, there's not a clear relationship between where in the gene the misspelling or variant is and whether or not there is peripheral schisis.
And one last follow-up question before we move to Dr. Maldonado. So were you saying that the macular schisis, so the central splitting, it can go away as somebody ages? Does that mean, is that correct? Did I hear that correctly?
Yes. Mm-hmm.
Okay, and so
yeah.
I was going to say,
yeah.
so does that impact vision? So does that mean vision loss either will stop occurring or that you can get vision back as you age?
Yeah, so maybe I'll back up to kind of the overall visual trajectory. Visual acuity or vision on the eye chart can be highly varied, anywhere between reports say 20/40 and 20, maybe 21/20, if you look at different natural history studies. Over earlier ranges of life, even looking over 5 to 10 years, people may not have very much change at all in their vision on the eye chart. With more years and decades, though, there can be a gradual decline in vision. And so when the schisis resolves, that unfortunately does not bring an improvement in vision. It may not change acuity very much, or it may be associated with a slight further drop.
Okay, thank you. And Dr. Maldonado, I'll move over you to now talk about X-linked retinitis pigmentosa. If you could just describe what the disease is and how it impacts an individual.
Yeah, absolutely. Thank you very much. So I think that the majority of the attendees may be familiar with the terminology of retinitis pigmentosa because it happens to be perhaps the most common inherited eye disease. And so I would like to highlight, as you know, that retinitis pigmentosa, it's inherited, and it produces the degeneration of the sensitive cells in the retina. And so typically produces, and typically in this order, night vision problems, followed by constricted visual fields, and lastly, affecting the central vision there. And so this is in general retinitis pigmentosa, but perhaps it's important to know that there are many ways to divide retinitis pigmentosa. One of them is by the inheritance mode. And so we have recessive forms. Those are usually the most aggressive. Then we have the dominant forms. And lastly, we have these X-linked forms. And those are associated to variants or mutations in the X chromosome. And so a few typical things about X-linked retinitis pigmentosa is that it's typically diagnosed in children, more typically in teenagers, and again will produce these vision problems and can lead to legal blindness by the age of 50. So it affects significantly the functionality of the patient, produces disability for many years, and when it's present mostly in males, with some exceptions in some females. So broadly, that will be a brief introduction to X-linked retinitis pigmentosa.
Thank you very much. And Dr. Qian, I would like to ask you now to talk a little bit about choroideremia.
Sure. Thanks for the questions, and thank you for all the attendees. So as my two colleagues have mentioned, these are X-linked conditions affecting mostly males, but especially with choroideremia, more and more, we do discover that female carriers can show variable presentations that are similar to the men, but perhaps at a later stage in life or at a decreased severity. And choroideremia, oftentimes the symptoms can be similar to what have been mentioned with, for example, retinitis pigmentosa, or be it X-linked or other ways of inheritance, mostly so it affects boys and can start early on in childhood. Specifically, it'll show up as difficulty with night vision. And of the different forms, the patients with choroideremia, oftentimes they will continue to have a gradual decline in vision, but they can often preserve excellent central vision for a good part of their adult lives. So oftentimes we'll see, for example, in clinic, people who are maintaining vision of 20/20 for their central vision, but with a very, very diminished vision of the periphery of their visual field. And when these people present to clinic, I would say as an ophthalmologist, it's actually one of the conditions where even prior to genetic testing, they can have a very representative or a striking appearance to the eye, to the way the back of their eye looks, in the sense that oftentimes when we look at a healthy retina, there's usually a very color, a pink or salmon pink hue to the retina. And in conditions of choroideremia, oftentimes because these people have a degeneration of the retina and the underlying choroid, hence the name choroideremia, the color of the retina shows very areas of hypopigmentation, where the back of the eye loses that healthy sheen, and it can look kind of patchy and hypopigmented. And oftentimes that's what leads to people or our colleagues to say, perhaps this could be choroideremia. We need to do genetic testing to further confirm that diagnosis.
So a follow-up question for either Dr. Qian or Dr. Maldonado, because you both mentioned that while it does predominantly impact males, there are some females who might have visual changes as well. So I guess my question is it because they have a mutation in a single gene, or is it because they probably have a mutation in both copies of the gene? And I don't know if it's different for choroideremia and for X-linked RP.
Go ahead.
Well, I mean, it's quite interesting because about 2% of patients with X-linked RP, females, would develop pretty severe retinitis pigmentosa. And it's mostly explained by a genetic phenomenon where the X chromosome could be inactivated. So randomly, the correct copy of the X chromosome would be inactivated in females. And because of that is that the female would present with the disease as well.
Okay. And is that a similar thing that you would see for choroideremia as well, Dr. Qian?
Yes, I think the principle of X inactivation, as Dr. Maldonado mentioned, is the principal theory of why this happens. Obviously, it's a complex process, and just as a review, as everyone remembers, so males have X and Y chromosomes. So if they inherit the mutation, it will for sure appear. Whereas for women, they have 2 copies of the X chromosome, and if one of the chromosome ends up having the mutation, but the healthy X chromosome compensates, then those people would not manifest themselves symptomatically. But as Dr. Maldonado mentioned, if there's X inactivation of that healthy copy, then the mutation on the other copy can, at that point, manifest itself. But it's very diverse in its presentation in terms of the severity and the age of presentation.
One of our speakers, Gerry, was just saying that one of his suggestions for us is to do a genetics 101 course. And I think this is telling us why we probably need to, because it's quite complicated when you start talking about the recessive and the dominant, and then the X-linked and the non-X-linked. So there is one more genetics question that we've got from our Q&A, which I think it makes perfect sense to ask here before we move on to talking about clinical trials and potential treatments. So somebody has asked if a father has X-linked RP, and I think it could work actually for any of these diseases. So if a father has either XLRS, X-linked RP, or choroideremia, what are the odds that his child, they said daughter, will also have the condition and or carry the genes? I don't know if anybody can do that math quickly in their head, or we can come back to that question as well, if that's preferred. Dr. Maldonado?
Yeah, maybe. So if a male has X-linked RP, so as Dr. Qian was saying, a male would have an X and a Y, right? X and a Y chromosome, and the mutation or the problem is in the X chromosome, right? So if that patient is going to have a daughter, he would pass the X chromosome with a mutation, and it will have a daughter who would be a carrier, right? But if he's going to have a son, it will pass the Y chromosome, and then it wouldn't have passed the disease.
Okay, so it's 100% chance that if you have the disease and you're a male, you will pass the X chromosome to your daughter, and they will be a carrier. And there is a 0% chance if you have a son that they will then be carrying it because you're passing the Y chromosome, which doesn't have the gene. Okay, thank you. So moving now to sort of, I think, the bulk of the conversation, which is really talking about potential treatment. So we know that for, at least my understanding is, for none of these conditions, there aren't any approved treatments yet. So I was wondering if each of you could share insights into either ongoing clinical trials or some promising areas of research that you are most excited about. And I think I'll go sort of backwards through the order and start with Dr. Qian on this one.
Sure. So actually, I did some looking back about research on choroideremia, and apparently I was pleasantly surprised to find out that actually choroideremia was one of the first diseases to be research sponsored by FBC back in the day. So as you can see, the research has been ongoing for many years, many decades, and thanks to FBC, those are the research that helped identify, the location of the mutation on the gene, and we move forward in the direction in terms of therapy. So far, there have been major studies and breakthroughs, specifically with the study of gene therapy in the approach of gene augmentation. So the idea is that you would carry a corrective version of the gene onto a virus vector, and then this would be delivered surgically into the eye, or specifically under the retina, into the back of the eye of people who have genetically proven choroideremia. And this has been studied both through several phases of study, going from phase 1, phase 2, and then finally phase 3. The latest results of the phase 3 studies actually were carried out in an international multi-center study in about 169 patients, all of whom were male. And basically, these patients were followed for up to a year to see the results of the study. All the participants in that study were adults, as in this was early study, so they wanted to start with people who either already had quite advanced conditions or who were older, and they wanted to test, of course, the tolerability, safety in adult populations first. And so the results of the study, they did show that some of the patients had gain of vision, but the rule that was set actually for approval, in order for this gene therapy to make it to approval by legal body agencies and bodies, was that they had to show that patients had more than 15 letters of improvement. So in the sense that they would get the therapy and then they were followed for a year, and if a statistically significant number of patients gained 15 letters of vision, then this would be a positive result to move forward for possible further steps to get the drug to market. And so there were some patients who did show improvement. It was a small portion. So if I remember correctly, it was 3 patients out of the people who received the highest dose of that gene therapy had improved vision, and then 1 person in a lower gene therapy dosage also increased. But this was out of 169 total patients. So for the FDA, the Federal Drug Administration, the study at that point showed a positive trend, but did not meet its end goal. So although it proved to be promising, this was not enough to get it approved as a approval to move forward to develop as a commercial product or something that will be covered. So those are the latest results. So it's been shown that it's well tolerated. It has a relatively good safety profile for a subretinal surgical product, but so far it did not demonstrate the endpoints that were set to meet further development.
Do you have a sense of anything else that's taking place in the choroideremia space of this gene therapy didn't quite meet its endpoints and possibly isn't being moved forward by the company? Are there other therapies, maybe not in clinical trials yet, but being researched?
Yeah, I think so as many of the audience know, the one approved gene therapy that's on the market currently, which is for RP65, is the same type of model using a viral vector delivery of a missing protein. And this seems to be, for choroideremia, a good model, just because of, the gene that's corrected in choroideremia is a smaller sized product. So these are better suited for fitting into a vector to then be delivered. Right now, I think researchers in the domain are looking at whether there's different ways of assessing what would be different endpoints. Perhaps 15-letter gain is very strict, and especially if we're looking at people who are already in advanced stages who are older, perhaps there are other parameters to better follow their disease progression. Perhaps there's other ways, for example, not only through reading letters, but through tests with special imaging equipment where we can track their progress and whether it can slow down the decline of their vision. So it's a lot looking at, so the molecule model seems to be a good fit. I think people are still looking at ways of perhaps diminishing the side effects that can come with this therapy, but it does seem to be promising. Perhaps the idea is thinking a little bit differently about what to use as measurements to better quantify and see what's the best age bracket for this type of therapy, and also what kind of tests are better suited to follow them over a longer period of time, because as we know, these are all diseases that can take many years and can be slow to progress. So perhaps 1 year is a short period to see the long-term effect.
That's really interesting that it's like the therapy itself, there might still be hope that we can still use this therapy, but we might need to be looking at different test results to actually see the effect. And I think it sort of shows, because you mentioned there's like one gene therapy for RPE65 mutations, but that's only one therapy so far. So the field is still at a relatively early stage of maybe understanding what are the exact right parameters for each different type of eye disease. Dr. Maldonado, I'll turn to you next to sort of a similar question. If you could talk a little bit about the landscape of therapies, either in clinical trials or in research for X-linked RP.
Sure. It's important to say that for X-linked retinitis pigmentosa, in general, we are a little bit more excited about the future. Certainly what happened with choroideremia perhaps was a little bit disappointing for patients, or for physicians taking care of patients with IRDs. But I think that was because choroideremia came a little bit earlier and had to suffer with those problems of the testing and the ways to prove that the therapy was working. So in contrast to that, X-linked retinitis pigmentosa has had some successful and promising outcomes in the trials. And so there have been phase 1 and phase 2 trials showing improvements in, for example, in the sensitivity that cells could have to light. So there's a test that patients have to go through that it evaluates the sensitivity of the cells in the macula, in the central part of the retina. And so these trials have shown that the capability of the cells to react to light has improved significantly. There were some improvements in other testing, such as visual fields, modified form of electrophysiology that's called FST and so forth. So good signaling of promising effect in phase 1 and phase 2. And now we are moving into these phase 3 trials, and it's very interesting to see that there are actually two companies that are sponsoring phase 3 trials, and one of them is the Lumeus study, and that one has completed recruitment, and nowadays we are recruiting for another study that's called the VISTA study. So bottom line, two sponsored randomized clinical trials, multi-centers, evaluating the efficacy of gene therapy here for retinitis pigmentosa, with the hope that it will improve overall the sensitivity, will improve maybe night vision perception, maybe visual fields. And certainly the hope that I tell patients is that we can stop the disease progression, and any improvement is always a bonus. That is something that we have seen in many gene therapies. Improvement is also possible to some extent. But in summary, there's more hope in the field of X-linked retinitis pigmentosa, and we're very much hoping that these phase 3 clinical trials show successful results. One other thing that I must mention is that these trials are using mobility testing also. So it's a maze where patients have to sort obstacles in different lighting levels, and seeing that the patient improves the mobility in different lighting conditions is a way to prove that the therapy is working.
And so you mentioned there were two different phase 3 trials taking place, which is fantastic. Do you have a sense of the timelines for when those trials will be over and we'll have the results from those trials?
So the Lumeus study completed recruitment maybe 6 months ago, and the VISTA study is still recruiting. Maybe recruitment is going to last 6 more months, and from there, it will take 5 years more or less until we have final data. But of course, all these clinical trials will report results at 1 year, 2 years. Will keep us updated with the outcomes there.
Perhaps. Great. We'll look forward to be able to share more data then, maybe relatively soon. And Dr. Huckfeldt, if you could talk now about X-linked retinoschisis and some of the clinical trials and research taking place.
Yeah, so my colleagues here set the stage so nicely, talking about the premise of using a modified virus as basically a delivery truck for a full-length gene, hoping that augmenting the retina or replacing, bringing a full-length copy of the correctly spelled gene would have a therapeutic benefit. What we've heard about tonight so far has been delivered by a vitrectomy surgery in the operating room with a subretinal injection of the gene therapy. And when scientists and researchers started developing genetic therapies for XLRS, they thought they maybe had it a little easier. We think of the retinoschisin protein that's encoded by the RS1 gene. RS1 is the gene that has variants that cause XLRS. We think of that protein retinoschisin as being like a kind of retinal glue. Maybe it doesn't matter what cell type expresses it. If you have enough of it floating around, will it, the question was, would it help restore some of the normal structure of the retina, getting rid of the schisis or separation we talked about already. And so unlike for choroideremia or XLRP, where you need very specific cell types to receive the correctly spelled gene and express the protein, now the thought with XLRS was maybe it doesn't matter what cell gets the gene. And that's important because it led to the question of, well, do we really have to go to the operating room with a surgery, or can we deliver the gene therapy in the clinic with an intravitreal injection? And in contrast to the surgical subretinal injection, we do intravitreal injections in clinic all the time as retina specialists. We use them for age-related macular degeneration. We use them for diabetic retinopathy. So they are a very different, simpler procedure. And this was especially attractive in XLRS just out of concern that the macular region where surgeons deliver the subretinal injection is maybe a little bit more fragile because of the schisis. And so a number of years ago, there were two first-in-human phase 1/2 trials that both tested whether intravitreal delivery of a XLRS retinoschisin 1 gene therapy would be number one, safe, and number two, have therapeutic benefit for XLRS. One of these trials was conducted by the National Eye Institute. The other one had a company sponsor. And you know, they had some similarities in their findings. Both found, not unsurprisingly, that the amount of virus that you had to inject into the vitreous cavity of the eye could incite some inflammation inside of the eye. We think of the eye as being relatively immune privileged, meaning it's a little bit hidden, so to speak, from the immune system, but that's not totally true, especially in the vitreous. That inflammation could be managed, though. It wasn't like it would have been preventive in and of itself. But at the same time, it wasn't clear at that time how much functional benefit there was from the genetic therapies. So while these initial studies were going on and providing us with, I think, very important and useful information, there was some basic science going on too. And this basic science was testing whether a slightly modified virus could be a little slippery, so to speak. If you used it to deliver a subretinal gene therapy, rather than the virus being limited to the area of the retina where the fluid and the gene therapy was injected, would it have the ability to spread a little further, make it past all the tissue barriers that otherwise would limit a regular virus to effectively treat a broader area of the retina with a subretinal injection? That type of virus is now being used in a phase 1/2 trial of now subretinal gene therapy for X-linked retinoschisis. Like all first-in-human trials, you know, any results are early and preliminary, but my site is not a participant in this trial. I've enjoyed seeing the data presented at meetings though, because it has, although preliminary so far, shown us that the safety profile seems to be tolerable of doing subretinal injection in these eyes. And there have been a number of participants where the schisis cavities close after receiving the gene therapy. You know, there's still all kinds of pieces of data that I look forward to seeing as they're available, but this was a nice sort of second chapter of gene therapy for XLRS. And for completeness, I should say that in the intravitreal studies too, there were a number of participants who had closure or resolution of the schisis cavities. So that's not unique to subretinal delivery.
So just a little follow-up on that. So you mentioned that this phase 1/2 trial is using a different type of vector than the sort of maybe traditional one that can go a little bit further outside of the injection site. Would this type of vector be useful for other types of gene therapies, or is it very specific for XLRS?
Yeah, wonderful question. And I hope it is useful in all kinds of scenarios if it is indeed found to be, you know, the secret to success here.
Sort of, I think maybe a follow-up question. I'll open it up to any three of the doctors. So each of you have talked very specifically about gene-specific therapies, which are some of the most promising, I think, and very specific ones out there. Are there any other therapies that you see that are being developed that could treat somebody with either choroideremia, XLRP, XLRS, that maybe are not gene replacement therapies and that seem promising to you?
So maybe I will highlight a trial, an international trial that's underway, being coordinated by our colleagues at Johns Hopkins in Baltimore. That is asking whether the oral medication N-acetylcysteine, which is approved by the US Food and Drug Administration for specific indications, including Tylenol overdose, whether that oral medication is able to slow the rate of progression and retinitis pigmentosa, period. So not XLRP, The hypothesis is it doesn't matter what gene is causing somebody's RP, but would this antioxidant and acetylcysteine be able to slow their rate of progression? So that is an example of what we consider to be a gene agnostic approach, where someone's underlying specific genetic reason for having a condition may not influence whether or not they would benefit from a specific therapy.
Okay. And actually there is a site for the I'll say called NAC, the NAC trial in Montreal as well. So one of Dr. Qian's collaborators, Dr. Kunakup, is involved in that trial. Dr. Maldonado, you've see you taking yourself on mute. You want to add to that?
Yeah, no, I think that so there are some therapies or ways to treat these diseases that are called gene agnostic, right? And it doesn't matter what type of gene the patient is affected by. And so one good example that seems exciting, I would love to hear from my colleagues what they think, but it's very exciting to have the possibility of the stem cells that are called chemically induced progenitor cells that could be injected in the eye. So the concept is that the patient has lost cells. They have degenerated, and now the patient is missing cells to make up for the vision, and we can kind of transplant or replace them by injecting stem cells. So we have some data from a phase 2 clinical trial that, again, is encouraging, showing safety and some improvements as well. So highly motivated motivating field, the stem cell approach.
Great. And Dr. Qian, do you have anything to add to that question?
Only if I put on my surgical retina hat, I just want to mention that, a lot of what we've addressed, the subretinal injections and also the ciliary therapies, it's always amazing, as my colleagues say, like it's showing safety and tolerability, but it's also something to keep in mind that all these approaches, it's an injection, but it does involve very delicate surgery. Basically, we call it an injection because the end result is we want to inject the product, which is often in a liquid suspended form, but to get access to that immune privileged space and go under the retina, this is quite delicate retina surgery. So just need to take that into account that, as I think some of the questions in the audience. So for example, a gene agnostic approach such as NAC, the supplementation, something that's much easier to kind of fulfill versus something where you have to deliver surgically the end product. And it's always amazing that we have great expertise in delivering these, and we're gaining a lot of knowledge and expertise in different approaches with, for example, RP65 and a lot of the up and coming clinical trials. But it remains a delicate procedure that needs to be done in really well experienced either research or academic centers.
Thank you. And just quickly before we get to audience questions, I was wondering if there was anything about the specific condition. I think you've talked about some of the maybe challenges or opportunities there are, but I'll start with you, Dr. Qian. Is there anything very specific about choroideremia as a disease, the way it presents, the way it impacts the eye, that either offers challenges or opportunities for developing new treatments that might be different than another type of inherited retinal disease?
Great question. I think, as we're mentioning, we said for now, looking at the horizon, I think the idea of gene therapy with augmentation of functioning copy is still a very possible and viable way looking ahead. I'm sure my colleagues will further discuss, there are other types of gene therapy that are coming up in different disease or mutations, including, for example, the gene editing technologies, or, the hot terms of CRISPR and such techniques where you're basically trying to edit out the spelling error in the gene, if you will. So, for example, for choroideremia, we know that it's a very diverse presentation in terms of the mutations that show up. So contrary to perhaps some other types of conditions, the mutations we find in different families tend to be very heterogeneous, meaning that even the most common genes will only account for example, only 10 to 15% of what makes up all the possible mutations in choroideremia. So those approaches is why I think for now the gene augmentation seems to be a more generalizable treatment, because you're just trying to supplement the missing malfunctioning protein, versus developing a technology where you're targeting specific spelling errors. Because there are so many different possible spelling errors in the choroideremia gene, it might be difficult to find a one-size-fits-all, or something that could be widely applicable to different types of choroideremia mutation.
Thank you. Dr. Huckfeldt, sort of similar question to you about maybe specific challenges or opportunities within the XLRS space.
Yeah, I want to echo Dr. Qian, because I think it is a luxury in XLRS too, that if we are thinking about genetic therapies, we have a gene that is small enough to fit into a viral vector we have a lot of experience with. So I don't think we need to look beyond gene augmentation, at least when thinking about that type of strategy. We just need a way to effectively, deliver it to the retina in a way that, as I think big, can help not just the macula, but maybe someday there's a way to stabilize peripheral regions of the retina as well.
Okay. And Dr. Maldonado, and think about XLRP that offers either like specific opportunities or maybe some very specific challenges when developing a therapy.
I think that XLRP offers, a good opportunity for testing gene therapy. Is certainly there was the intravitreal approach, injecting gene therapy, which didn't work well. And now we are more comfortable with delivering the therapy subretinally. It seems like it's going to be effective. And for patients, injecting the therapy underneath the retina, it just has the logical concept of injecting the medication very close to the sensitive cells. And that's why it's thought that it could be more effective. But I think that is the best route to treat the X-linked retinitis pigmentosa. So the challenges are more into patient meeting criteria for the trials rather than the delivery of the gene therapy by itself.
Okay, thank you. I can see we have a bunch of questions already, so we're going to move into our audience question and answer session. So I will look at the questions here, and you can also, so the two ways you can ask questions is you can put your questions into the Q&A box at the bottom of your screen, or you can email education@fightingblindness.ca. So that's education@fightingblindness.ca, and my colleague Morgan will send me the questions. So there's a lot of questions here about clinical trials. So I think a few general themes are coming up. First of all is about how are there opportunities to volunteer to participate in studies? Some of these people are asking specifically for, say, XLRP or XLRS, but I think it's like a general theme. And also, how do you keep informed about clinical trial progress as it's happening? And then the third question, which is in the same theme, is what would you advise for a person participating in a clinical trial? So many questions. So why don't I start off with the first one about opportunities to participate? How do people find out about clinical trials? Anybody want to tackle that one? Dr. Maldonado, go ahead.
Let me just throw an important idea. It's a very dynamic field. And so patients can be looking for information on the internet. Usually the website Clinical Trials has a comprehensive listing of some of the trials there. And there's a lot of information on the internet. But certainly it's always best to have the guidance from your IRD specialist, who can tell you if one option or one clinical trial might be better for you. Also, the IRD specialist can tell you if you actually meet criteria for that study and so forth. So I usually tell my patients, that in addition to having their eye exam, we have the chance to go over the possibilities that are available. And not surprisingly, on a year-to-year basis, there are new things that we can comment with patients. So I highly encourage patients to check with your IRD specialist for these opportunities.
And yeah, to sort of echo Dr. Maldonado is saying, there's a few websites that you can look at that have information. So there is clinicaltrials.gov, which is the largest, I think, source of information about clinical trials. On the Fighting Blindness Canada website, we actually also have a list of clinical trials specifically for inherited retinal diseases, where we will link you to the clinicaltrials.gov website, which has more information about eligibility and the different sites. It's always really important, Dr. Maldonado said, to talk to your doctor before participating in a trial. And if you've got any questions, you can also email our health information line. And Morgan and Ushani can send you more information in the follow-up email. But we have a health information line that you can ask questions to. And Dr. Huckfeldt, I can see you ready to speak.
Yeah, I am. I absolutely agree with what everything Dr. Maldonado said. I just might add one note of caution about clinicaltrials.gov. That .gov is a little misleading in that there's no vetting of what gets put there. And so something being listed on clinicaltrials.gov does not mean that it is based on rigorous preclinical science or is being conducted ethically. So all the more reason, to have a good relationship with your IRD specialist or retinal physician so you can go with questions.
Thank you. Go ahead, Dr. Qian.
Yeah, I was just going to say they have a disclaimer now on the clinicaltrials.gov on top to say that it's not governmentally approved, but it's always important to, I think, sometimes it's a small letter, and so we have to be conscious of that. And also just to add that, for example, with FBC in Canada, we, as you know, Larissa, we have a consortium of Canadian specialists who follow patients with IRD across the country. And if ever any of them engages in discussions about possible participation in a clinical trial, especially if it's outside of Canada, for example, having to travel to attend or participate in a trial, we always try to have actually a consortium discussion amongst the IRD specialist providers to see in those situations what advice would give to the patient. So it's really good to have that network because sometimes the trials can also have direct to patient communication, and I think it's really important to not just communicate with, for example, private sponsors without the guidance of your eye care specialist or IRD specialist, because you want to make sure that the conditions are applied to you or someone who knows your eye health the best.
Actually, just follow up with that. There was another question here about, like, when you're talking to your patients about clinical trials, how do you advise them about participating? And there's some questions I think we'll get to also about eligibility criteria, but specifically when you're talking to a patient, how would you help them decide if they should be interested in a clinical trial?
I guess I'll start. I mean, I just have an open discussion. I like to keep it open just to see how much material reading or research the patient has already done, and I'm there to kind of supplement additional information, especially for some of the trials. For example, we mentioned some of them being more gene agnostic. We will talk about the level of implication, be it supplementation versus something that is more surgically based, and also kind of talk about the things to keep in mind being important is that if they do choose the pros and cons of one trial, if ever in the future there is a gene-specific clinical trial that does come later, what that means for them if they decide, for example, to go with one trial versus another, because usually that would become an exclusion criteria if they choose to participate, especially a surgical trial. That would basically, they'd have to decide on which one is the best fit for their needs and moving forward with that decision.
Thank you. There's a few questions about eligibility criteria. Dr. Huckfeldt, did you want to jump onto that question though first?
Yeah, thank you. If I can just add, you know, when I sit down to talk to somebody, a big part of the discussion is making sure their expectations of what an investigational therapy may or may not be able to do is a big part of it. So for example, some of the trials we're in right now, the hypothesis is stabilization, not improvement of vision. That's a really important thing to be comfortable with and understand, right? And just helping somebody understand their comfort or discomfort with all the uncertainty that comes with being in a trial, where there's not a guarantee of benefit. There is risk that goes with it, and everybody's kind of thermostat on that issue is set at a different point.
There were some questions generally about eligibility criteria. I don't think it's, I'll get into the exact specificity, but maybe does somebody want to talk about how eligibility criteria are decided for a clinical trial? For instance, why might there be a maximum age limit, or what somebody said that they tried to join a trial and their vision was actually too good to join the trial. So can you explain a little bit about how, in general, eligibility criteria are defined? I'm going to, Dr. Maldonado, there you go.
Yeah, no, I mean, I think that it's quite interesting that the patients could find that they are either too good for the trial or too advanced for the trial. And that frequently creates frustration in the patient. You know, they know their gene and they finally know that there is a clinical trial for their gene, and they come to evaluation and they don't meet criteria because, yes, they could have advanced disease and they don't qualify, or because their vision is too good for the criteria. And so those two scenarios can happen, and sometimes it's quite difficult for us to find patients that actually meet criteria, so it's not too easy to recruit patients. But the guidelines or the entry criteria are essentially set by the sponsor of the trial. And part of the reasoning for setting those criteria is that you want to have the patients that could be good test takers, that could help you to have signaling of the benefit of the medication there. So it is a predefined criteria that is thought with the purpose of maximizing the capability of finding the benefit of the therapy.
Thank you. And there was also a question about placebo. So in the clinical trials that you're talking about, would there be a potential to go through the clinical trial but be receiving a placebo if you were doing, say, a gene replacement trial?
So that is something that regulatory agencies want a comparator. And so if we're talking about a surgical trial, you know, it's not ethical to do a sham surgery and deliver a sham gene therapy. So in a surgical gene therapy trial, for example, the quote unquote placebo group often ends up being a group of people for whom the therapy is delayed. So in the XLRP trials, for example, one of them, the control group was people who had to wait a year to receive the gene therapy. Other trials have taken a similar approach, at least with regard to surgical treatments.
Okay, thank you. And there's another question, I think that would be for you, Dr. Huckfeldt, about the difference between, maybe clarifying between the peripheral schisis and macular schisis. This person is saying their grandson has X-linked RS, but whether it's peripheral and macular, they have never been told.
Yeah, thank you for the question. Just based on what we know about X-linked retinoschisis, I would assume that nearly everybody affected by it has macular schisis. So that may not be specified, but I would assume that is part of what the physician is seeing. What is, again, more variable is whether there is peripheral retinoschisis or not. But that's, you know, that's always a good, that type of question is always a good thing to ask an ophthalmologist, whatever the flavor of the question.
Okay. There's a few questions about maybe sort of broader things that somebody might be able to do. Somebody is saying, I suffer from RP and my vision is being reduced day by day. And then other than, for instance, gene therapy, is there anything that can help my vision reduce less, such as eating habits or anything I can do to have precaution for my eyes? And somebody else was also asking about acupuncture. So are there any sort of maybe non-traditional therapies or lifestyle changes that you might recommend to a patient if there's not a treatment available? I'm going to go with Dr. Qian.
Sure. Good. All right. Yeah, so that's that's the part of the field where there's a lot of I would say diversity of what approaches at least patients that I see have kind of asked me about different supplements and different life habits. I would say from my perspective, so there's we based our recommendations based on scientific research. So currently there's no such really strong evidence research that shows that any approaches such as those, except for example, avoiding a lot of direct sunlight and Stargardt or things that could, in that specific condition, deteriorate the condition. But in all other conditions, I would just say, I would advocate for a healthy way of life, healthy diet. If the patient would like to try alternate therapies, I just, as long as it's not something that leads to harmful side effects, I think it's up to them and it's free for them to try it. Although I can't say that I can either corroborate the beneficial effects or not. But for me, I think if they want to, then there there's flexibility to kind of do that in parallel, and I continue to follow them and see how they continue to fare in time.
Yes, I think as a follow-up question, they're saying one of their doctors recommended that acupuncture can maybe help with X-linked RP, and so I think they were just wondering if there's evidence behind it. But I maybe the evidence isn't very strong. I wonder if anybody else has any comments on that one.
I mean, I have heard patients doing acupuncture. There is also electrotherapy that's given to electrodes around the cornea, also to try to give shock waves to the retina. Special vitamin cocktails, and so alternative medicine also used for retinitis pigmentosa. I mean, the honest answer, I think that there's no data supporting those treatments. I haven't seen a patient getting better with those therapies. And so in general, I tell my patients that if there's something safe that they want to try, that's fine. As long as they are not spending a lot of money, they are not being charged for a treatment that has not been proven to work. That's what I usually tell them.
Thank you. This maybe I think is a quick one. Somebody's saying, I have RP. Should I see an ophthalmologist or an optometrist? Actually, Cynthia, I'll turn to you as sort of the Canadian clinician in the group.
Yeah, so usually the portal to seeing an eye care specialist is an optometrist first, and oftentimes optometrists will then refer the patient to an ophthalmologist if on their initial exam there are any signs suggestive of a inherited retinal disease. We do work closely with optometrists, but ultimately to make the diagnosis, the follow-up, the recommendations for therapy, the clinical trials, that would take the expertise of an ophthalmologist, specifically, as we've said here, someone who has experience with inherited retinal diseases or an IRD specialist.
I think we'll probably have time for one more question. I'm going to start with this one. I think the interpretation, Maya, is it says, does RP cause imbalance to the individual? So I'm interpreting that as being, does somebody who have RP maybe have less balance or struggle with mobility? Is that a symptom that somebody with RP might have? or if there's another interpretation you take from that question, please feel free to.
I think if vision is compromised by anything, and then if other senses are compromised, if there's peripheral neuropathy, all those things can kind of be insidious in terms of how affecting how somebody moves in the world and their confidence and stability. So I have had, to address this question, I've had a number of people over time where as they age with RP, they become a little bit less physically confident. And a few of them have actually sought out physical therapists who specialize in kind of balance in anybody. And they have found that helpful. So speaking anecdotally, yes, I think impaired vision in general is something that can contribute to altered balance.
Thank you. So I know there's been some questions we didn't have time to answer. Some of them also weren't specific to the X-linked conditions we were talking about. So we haven't addressed them today, but please feel free to contact our health information line at healthinfo@fightingblindness.ca, and we'll do our best to answer your questions as well. So I'm sorry for everybody I didn't get to your questions. But I want to now thank our 3 wonderful experts who have joined us today for this really, really engaging discussion. So thank you, Dr. Maldonado, Dr. Huckfeldt, and Dr. Qian for being here today.
Thank you for having us.
Yeah, and you're welcome to leave, or we're going to be on this webinar for another 10 minutes. So feel free to stick around as well if you want to. And I'm going to turn it over to my colleague Morgan now.
Larissa, and thank you so much to our panelists. That was a really informative discussion. Larissa and I were talking about this earlier last week, and despite the fact that I've now worked in sort of the vision loss field for, oh gosh, about 20 years, I really didn't know that much about X-linked RS and choroideremia specifically. So it was really interesting for me to learn a lot more about those conditions tonight. So thank you for all of that great information. So I am here to sort of pivot our discussion a little bit and move away from some of the science and the research, and we're going to have a bit more of what we're calling community connections. So we are piloting this new series, as I mentioned at the beginning. So we've got our research updates and our Ask the Expert sessions that you've come to expect and love from Viewpoint. But we're adding this new element where we're going to have the opportunity to go into smaller groups and to have a chat with others who are living with IRDs. So we're going to shortly be moving over from this webinar platform to meeting rooms where you can meet other people and engage with families and people who are affected by X-linked conditions. Whereas this session right now that we're in has been recorded and will be shared on our YouTube channel later, the Community Connect sessions are not recorded or shared. So for these sessions, we have 2 wonderful moderators who I'd like to take the opportunity to introduce them to you now and give them a moment to speak about their experience. So I'm going to ask Alexis and Gerry if they can unmute and put their cameras on, and we'll have a little chat. I'm just going to introduce them really quick while they do that. So Alexis Nickerson is originally from Halifax in Nova Scotia. Alexis is a physiotherapist specializing in complex pain and prenatal care. She is a mom of 2 athletic teenagers, one of whom has X-linked RP. She and her son compete in goalball, which is an amazing Paralympic sport for people with vision loss, and she also enjoys rock climbing with her family. And then we have a longtime friend of FBC, Gerry Chevalier, here on the call, and he is a native of Edmonton. His background is in computer science, and he was an IT consultant where he developed and managed systems for small businesses while he adapted to total blindness with assistive technology. He's worked as a product manager for Humanware and really specializes in assistive tech for people with vision loss. So thank you both for joining us. It's really great to have you both on the call. I'd love to invite each of you just to share a little bit about who you are, sort of what your diagnosis is and how it affects you, and what sort of you're hoping to share in our breakout sessions, which will be coming up. So Alexis, maybe I'll start with you if you don't mind. Do you mind introducing yourself?
Yeah, no problem. Thanks for having me. And hi, everybody. So yeah, my name's Alexis Nickerson. I have, as Morgan just said, I have retinitis pigmentosa. And my husband and I have two, very busy teenagers, and one of them has RP, as Morgan mentioned. I actually wasn't fully diagnosed until about 6 years ago. Actually, when my son was diagnosed, so I was originally diagnosed with retinopathy of prematurity. And it wasn't until he was diagnosed that we also learned that I have RP. So while that was, pretty devastating, especially to learn that that he has RP, along with myself, we've really tried to continue doing everything that we love. Many of the things that Morgan mentioned. He's also he's a competitive gymnast, and he's been able to keep that up with some adaptations certainly in place to make a pretty risky sport a little bit safer for him. Um, and we're a really active family, so we really enjoy things like rock climbing, surfing occasionally, paddle boarding. And we've really just tried to keep doing these things with again with some modifications. Um, and as Morgan also mentioned, we both play goalball, and we've really found some great community in goalball, both here in Nova Scotia. We have a great program here. We've met a lot of friends here and across the country, and we're really fortunate for that. So we've had some great support, not only from goalball, but from friends and family. And that's really made things a lot easier. And I think that's one of the things we'll talk about in the next section. With all the positive things certainly haven't always been easy. There's been lots of challenges along the way. And we'll talk about that again more in the next section. But I'm really looking forward to meeting everybody in that in the next section, to hearing your stories, to hear not only your successes but your challenges. So I hope you'll all join us, and I look forward to meeting you shortly.
Fantastic. Thank you so much, Alexis. Gerry, how about you? Do you want to give a quick intro?
Thanks, Morgan. Yes, hello, everyone. Glad to be here with you. I am now, I do have X-linked RP, and I'm 72 years old now, so the degrees has progressed fully. I'm totally blind. I was able to go through school and get my education and start my business. I was an entrepreneur developing computer systems for a small business, and all of that without being legally blind. But I was diagnosed at age 26, 1979. And I knew what RP was like because, being X-linked, I had several maternal uncles who were blind. So as a youngster, I saw the effect on them. And so when I was diagnosed, I still was able to successfully do my work. But as the 1980s progressed, it started getting harder and harder to see the computer screen, and my low vision was deteriorating. And so it was a very stressful time. My wife and I also had two young kids, a 1-year-old and a 3-year-old at the time when I first decided I needed to approach CNIB. And although I knew about technology, I didn't know what kind of aids might help me with my low vision. So my journey is really one of adapting through a 40-year employment history to try and keep my business going and make sure I could do the work I needed to do. And it's also one of networking, because I learned so much from people I met through CNIB who were able to get me started on the assistive technology adaptations. And so other people I met who worked in the computer field and who were blind as well, that kind of networking really, really helped me. And so even today, I still network. I have a peer group that I work with, coordinate a peer mentoring group, and we still exchange information once a month on Zoom about how we deal with our vision loss. So as Alexis said, I also can share more information in the next session, but I'm really looking forward to hearing your stories, your journeys, and how you, what adaptations and strategies you use to deal with your vision, because I'm sure there's still more I could learn from others. So I look forward to that in the next section and hope you can join us.
Fantastic. Thank you, Gerry.